So tonight, I really want to talk about the state of menopause in 2026. And what really got me thinking about this is that for so long, menopause was not on the radar, not in schools, not in training. Then we sort of learned it's a thing. And it's not just like a year-long thing, it's like a decade-long thing. Then we started talking about no, we're postmenopausal for a third of our lives. But what's really, really important is how we treat the body between 45 and 55 or 40 and 60 is going to set up the next several decades of her life. And not only that, but involves every single specialty that's here. So it involves, your brain, involves neurology, your mood, involves psychiatry. It involves our hearts, cardiology, it involves our bones. So that's our sports medicine, that's our PM&R, that's our endocrinologist. It involves all of us. And that's really, really crucial, is that menopause does not belong to one specialty. In fact, it crosses almost every specialty. And so that's really what I want to talk about tonight, right? So I got to thinking, it's not just about your period stopping. Menopause itself is an independent risk factor for heart disease, for bone loss, for osteopenia, for osteoporosis. It is really going to change how we build generational health. All right, so I actually have objectives, and this is an accredited session. So the objectives for tonight is recognize common symptoms of perimenopause and menopause, which I know many of you already know how to do, so we won't spend too much time there. I want you to be able to understand some of the findings from the large randomized clinical trials. And that includes my favorite study, the Women's Health Initiative. Why? Because around here, the Women's Health Initiative is the framework for the safety and efficacy of menopausal hormone therapy. The WHI was not a bad study. It was really just the way the media portrayed the results. That was where we had the downstream negative effects. We're going to talk about the risks and benefits of menopausal hormone therapy. And most importantly, we're going to talk about the risks of not prescribing menopausal hormone therapy, which include worsening quality of life, which includes a rise in compounded or unregulated medications, and its impacts to the economy, which are real. I have some other goals. I wanted to invite you to this beautiful space, whether you're online or you're here. I kind of feel like a pastor, all of you online. But no, I'm in fact a doctor. But I wanted us all to meet, whether it was virtually in the comments or it's here in person. I wanted to learn your specialty. I wanted to learn what brings you here. I also want to network and I want to expand. And I really want to meet you where you're at, whether it's at your institution or building your own practice. I want to empower you to learn more, whatever your specialty is. And of course, I want women to get better support. And so I love teaching. If I can teach one woman, I feel like my job is done. But if I can teach one clinician, I can then help thousands of women. And that's always really been my mission. Okay, so I never thought I was going to become a menopause doctor. That really wasn't in the cards for me. So I always wanted to take care of women. So I started my career in OBGYN. And after a lot of late nights and surgery that I just didn't feel like was perfect for me, I transitioned into internal medicine. During my internal medicine years at Case Western, for any of my fellow residents who are there with me, I became known as the former OBGYN girl. So everybody asked me, hey, I have this patient and she just got pregnant. Can she take Allegra? And I said, yes, she can. Or they would say, Heather, could you do a pap smear? I just saw you put an A-line in somebody in the ICU. So what I realized was there was a big gray area between my brilliant internal medicine gynecologist who could deal with patients with, 16 medications, right? And their long-term health and their chronic disease management. But they didn't want to touch anything in the bikini area. And my gynecology colleagues, they were amazing at surgery and late night decisions that I was not good at, and obstetrics. But to also then say, now you need to also manage someone's chronic health, not that they couldn't, it's just a lot to handle. So there was a gray zone here. So I then did a fellowship at Cleveland Clinic, and my mentor, Dr. Holly Thacker, is the one who trained me. She taught me everything that I knew, and I really do owe so much to her. And then I really took that and just ran with it. I saw women come from all over the country to come to Cleveland, which we dubbed the mistake on the lake, and say, I don't know what's wrong with me. I've been to all these different doctors. Something is bad news. And really, it was the same thing over and over again. It was perimenopause and menopause, and women having no idea how to connect the dots. So then I went to Ohio State, where I told you I did my very first grand rounds in 2017. And then I went to Brigham and Women's, and I built the midlife and menopause clinic there. Then I worked at a telemedicine startup that was VC backed for a few months. And then I started my own practice. So that, my friends, is how I became a menopause clinician. And really, truly, truly, I have to thank all of my patients. Anyone who's trusted me with their healthcare over the years has really left an imprint and really also furthered what I learned from my training and my fellowship. It was really my patients and their trust in me that has gotten me to this point. All right, so just some of my disclosures. So I'm the founder of the Collaborative, which is telemedicine practice. I'm the founder of the Academy for Advanced Women's Health Medicine, where I train clinicians and teach them this type of information. And my only sponsor is from Cozy Earth, and they sponsor my podcast. So a couple things. One, I could talk about this topic for an entire 24 hours without coming up for air. So we're going to try and keep this to a little bit around an hour, but this is a topic that it's just so near and dear to me. I have to make sure I try to stay concise, but I definitely can talk a lot. These are my medical opinions, and they're based on evidence and facts and research and my clinical findings. And what's really important, what we're going to discuss tonight, is what do we do when we don't have the information that we need? Because a lot of times this theme comes up again and again, which is that we do harm in the name of do no harm. Because we don't know what to do, we do nothing. And that in and of itself can be absolutely detrimental to women's health, right? And I was a part of the FDA panel on talking about menopause. And we'll talk about that as we keep going. All right, this is available for CME credit. So if you registered, you're going to get an email with all the instructions. And if you're watching online and you want to claim CME credit, follow along. We will put the link up on YouTube soon, and you can register there. All right. Now let's get into my genius zone, the facts. All right, definitions. Why is this important? Well, if you are on social media, which you might be, if you're not on social media, great, tell me how you do it. But if you're on social media, you've noticed some change in language recently. You've maybe even heard me go from saying hormone therapy or HRT to MHT and putting a strong emphasis on that. Why? Well, technically, it's the correct term. Most women know the term HRT, and so we say that. But as the expert menopause panel was coming up, we really wanted to make sure we were providing evidence that we knew our stuff. Menopausal hormone therapy is for women who are taking hormone therapy around the time of menopause, whether that's natural menopause or natural menopause. You could have your ovaries surgically removed and either have just gone through menopause, and then that's still you having natural menopause, but just having your ovaries removed. So that usually includes an estrogen, plus or minus a progesterone if you have your uterus, plus or minus testosterone, and plus or minus vaginal estrogen. Now, you'll hear me say a lot too that menopausal hormone therapy doesn't have to be like the estrogen and the progesterone and the testosterone. It can kind of be a mixture of things. There could be women who take just testosterone, maybe some progesterone, maybe just vaginal estrogen. Maybe they're on progesterone and a dab of testim gel. That's still menopausal hormone therapy, even if it doesn't mean the estrogen. So menopausal hormone therapy is the correct term for women going through natural menopause who then choose to start estrogen plus or minus a progesterone if they have their uterus, plus or minus testosterone. HRT, what a lot of us still say, and I still say it sometimes too, is really hormone replacement therapy. The emphasis on the R when you're physiologically replacing estrogen if you have menopause early. So what's early? Before age 45. So before age 40, if you go into menopause, that's premature menopause. Before age 45 is early menopause. And those are crucial because that's kind of like having diabetes, where when you are diagnosed with type 1 diabetes and you're insulin dependent, we give you the insulin to make sure that your body is going to metabolize the sugars and carbohydrates correctly. When you go through menopause early, we know that without it, women are at increased risk for what? Heart disease. That's a theme we're going to come back to a lot. as well as bone loss, as well as severe worsening of their quality of life symptoms. So for women under age 45, there better be a very damn good reason why we're not prescribing estrogen, because without it, they're actually at increased risk for a worsening health outcome. Now, bioidentical hormone therapy is simply a slang term, but it means estradiol, and these are all plant-based. They come from plant sterols, both 17-beta estradiol and progesterone, or micronized natural progesterone, or prometrium. So bioidentical is just a fancy way of saying it's plant-based, but these medications are not synonymous with compounded, which a lot of women still think. So compounded hormone therapy could be bioidentical. FDA-approved hormone therapy could be bioidentical. So if it says estradiol or if it says progesterone, that just means it's plant-based. Ideally, you want FDA-approved menopausal hormone therapy. One of the reasons that so many women get compounded hormone therapy is truly because we don't have enough clinicians who understand how to prescribe it. But we're getting there, right? Okay, so that's what bioidentical means. Not all menopause is the same. So we talked about natural menopause, right? We talked about surgical menopause is when you've had removal of both of your ovaries. Not one ovary can work just fine, but both of your ovaries. Now, for women who've had a hysterectomy, but their ovaries left in place, this is always one of those, how do I know when I'm actually going into perimenopause or menopause? Because you left my ovaries in. So how can I tell? Because I'm not getting periods anymore. And sometimes those ovaries work perfectly well. And sometimes if the surgery was difficult, because I did stick around to see some hysterectomies, but not all 4 years, if there's not great blood flow to the ovaries, those women can go into perimenopause or menopause a bit earlier. So you could have surgical menopause, which is obvious. Both ovaries are taken out. If they just take out the uterus, a hysterectomy, but leave your ovaries in, it's hard to say if you're going to have an earlier perimenopause or menopause, and one that may actually signify the necessity for hormone therapy. So something to look out for our surgeons who are taking out the ovaries. So we talked about early menopause before age 45 and premature menopause before age 40. The leading cause of premature menopause is probably premature ovarian insufficiency. I find this diagnosis to be quite fascinating. I want to learn so much more. The leading hypothesis is that it's more autoimmune mediated. So just like we have autoimmune hypothyroidism, where the body's attacking the thyroid for no good reason, there may be also an attack on the ovaries. These are both rapidly dividing cells in the thyroid, as well as ovarian cells, and therefore causing them to kind of atrophy sooner, putting you into early menopause. I've had patients as young as 17, 22, 27 on their menopausal hormone therapy. And then there's perimenopause, a topic near and dear to my heart, because I'm also going through perimenopause, which was fun to do as I was writing a book on the topic. And this is the time leading up to menopause. And you can divide this into both early perimenopause and late perimenopause. Early periods start to maybe become more frequent or more heavy. And then later perimenopause, they're starting to really space out. So periods are now every few months. And this is really important because your symptoms can shift from early to late, and then again when you go into menopause. So I always say to my patients, it's definitely a journey. And the symptoms you start out with may not be the symptoms you have again in 12 months, may not be the symptoms you have again in 3 years. I know. So what is hormone therapy approved for? There's 4 FDA indications, and that's persistent bothersome vasomotor symptoms, hot flashes, let's say what it is, night sweats, hot flashes at night, waking you up, genitourinary syndrome of menopause, and osteopenia. Those are the 4 and the 4 only. Now, don't worry. I know you have questions, right? Like, what about using hormone therapy for mood or for joint aches and pains? So here's what I tell everyone who takes one of my courses. Most women have one of these 4. And if you have a patient who hasn't had a bone density scan, it's a good time to get one because you will find osteopenia more than you think. And great, then you have an indication. Is it important that you have an indication? Not necessarily. However, oftentimes my point is that you can find an indication. Now, I also used to say when I was teaching residents, when I was teaching the residents at Brigham and Women, and we'll talk about this when I talk about GSM again. Research shows 50% of women have genitourinary syndrome of menopause. But if you ask me, all women have GSM. It's just whether they feel it or not. Now, I know that by the book, the indication is for pain with intercourse or recurrent urinary tract infections. But almost all women will have GSM because as they lose estrogen, the pH of the vaginal tissue is going to go from a acidic pH, go up to a basic pH, and that is going to put them in that GSM position, basically. So the big question is, who can take menopausal hormone therapy? Well, we're going to get to this. This is what I teach, of course, in like my classes, and really what I want to take away with today is that most women are candidates for menopausal hormone therapy, because as an internist who's prescribed many medications over my years being in residency and then being a young clinician, I've prescribed many more dangerous medications than a transdermal estrogen and bioidentical progesterone. Now, that's just one formulation and one route, but menopausal hormone therapy is extremely safe, and that's what we're going to talk about. So what about off-label uses? So it's nice to have an indication just because you feel good checking the box, but many women find, and many clinicians who routinely prescribe menopausal hormone therapy will easily see and agree that mood symptoms get better. They have less irritability, less anhedonia, less anxiety, less joint aches and pains, less dry skin, itchy ears. We hear that all the time. Dry eyes. I actually have a patient who is she's an ophthalmologist. And she came to me and she said, I just have the craziest dry eyes and I cannot figure it out. That wasn't her main presenting symptom, but one of them. And when she came back to see me, she was like, I cannot believe that dry eye symptom is gone. It's just that estrogen is from head to toe. And this lie we were told was that these are our sex hormones. They help us, regulate periods or start our periods, or we get pregnant or we have babies and then we breastfeed, but they impact our whole body, and no bigger place do they impact us than our brain, right? So it impacts so many things. So we use menopausal hormone therapy off label all the time. And we use many medications off label all the time, right? And before we were using menopausal hormone therapy at this accelerated rate of 5% of women, the majority of women were given off-label SSRI use. And so we can't sort of say one's bad and the other's okay, especially when we know how safe menopausal hormone therapy is, not to mention the preventative benefits. Now, another thing that I like to talk to my patients about is using menopausal hormone therapy as a diagnostic tool. What do I mean by this? So this might sound crazy, but patients come to me all the time and say, could my joint aches and pains be from menopause, or is it osteoarthritis? I did an x-ray and everything looks fine. I've been on non-steroidals and they're okay. And I say, why don't we try menopausal hormone therapy? That's crazy, right? No, it's not, because this can be diagnostic. For many patients, if they've tried SSRIs for mood, or if they've tried non-steroidals for their joint aches and pains, or Cymbalta for their fibromyalgia, it is imperative that you give them a couple weeks trial, as long as they're safe to take estrogen, which most women are, because in the vast majority of cases, that symptom gets better, they get the right diagnosis, and then they're off the wrong medication. Then they get the long-term preventative benefits from estrogen. So this is my answer to, is it perimenopause or menopause? Or is it just that my mother-in-law lives in my house? And so, sometimes adding the estrogen as a way to help diagnose, rule something in or rule something out, is extremely helpful and something that doctors should consider in their toolkit. Nothing will happen if you take estrogen for a few weeks, and you're a good candidate. So the implications of not having more studies on menopausal hormone therapy is this: we're not going to have big randomized placebo-controlled trials on menopausal hormone therapy. And even if we do, and we get the funding, which is probably billions of dollars in multiple different sites, we're not going to have these results for a very, very long time. And if we just hang our hats on that and say, we don't have the proof, we don't have the studies, without using what we see clinically, then we are going to do harm in the name of just freezing. In the name of saying we don't know and we do nothing, the patient may not get treated. So every year, the USPSTS gives a grade D for the primary prevention of hormone therapy in the primary prevention of cardiovascular disease, bone health, and et cetera. And every year when they do this, which is every couple of years, so they haven't done it in a while, everyone texts me and says, can you believe it? And I'm like, yeah, yes, I can believe it. But that doesn't mean that we have to sit around and be labile because of that. Because we don't have the studies doesn't mean that we cannot still use our clinical knowledge and our clinical findings and listen to the patient in front of us to help her, right? So how do they give a grade D? Because of the harms. And we're going to go over these harms, right? Increase in blood clots, which really is mitigated on transdermal, which is also going to mitigate the risk of stroke. Dementia was only found in the WIM study, which was women on hormone therapy over age 65, way out of the 10 years most women should be starting menopausal hormone therapy, and breast cancer, which we're also going to talk about because the formulation matters. So what if these harms are actually not harms at all, right? And what if the benefits are literally way longer than this? Because if anyone here is also a patient, they know that the benefits of menopausal hormone therapy are massive. And where do you see reductions in diabetes? Where do you see reductions in cardiovascular disease? Where do you see reductions in death from urinary sepsis? Where do you see that, right? Now, I'm not hanging my hat on that. That's not what this conversation is about. It's not about lobbying for the United States Preventative Services Task Force. It's really just to talk to clinicians and to really say, these guidelines are hard to move because we're never, if we're waiting for these studies, going to have them. So midlife medicine matters for everyone. And one of the reasons I'm so excited you guys are here is because I got to chat with you and see that there's clinicians so many different places, right? From family medicine to occupational medicine to high-risk breast, to gynecology, to oncology. Like, it's so fun to see so many clinicians here. What I wish we had was neurologists and endocrinologists and surgeons. There's so many specialties where menopause hits. So the scope of the problem is massive. I don't think I need to tell you, but very briefly, 75% of women will have symptoms that last on average 5 to 7 years. And I bet you that is an underestimate because we're not good historians. So when we think back, when did this really start? It's probably, a lot of my patients will say, oh my gosh, it's been at least 10 years that this has been going on. And this has to stop. This is why menopause education is so important, because we don't want our daughters to do the same thing and wait years and years and years while they're suffering, right? There's deep-seated biases that we're starting to uncover. But again, the problem is not just with the way it's going to impact health, it's also the economic outcomes. So the medical consequences are huge. I don't know about any of you, but when I was in academic medicine, I would work with the residents in resident clinic. And the residents would usually see patients who are on Medicaid, Medicare, right? These are underserved patients. And never once did one of these patients ever kind of bring up their menopausal symptoms. They had so many things to talk about: their high blood pressure, their diabetes, why they weren't getting their insulin, why they couldn't pay for their medications. Their hot flashes was just like not on the table. But what if we treated all those women with menopausal hormone therapy that actually needed it? They would be so much healthier, right? So it impacts everybody. So menopause is an independent risk factor for cardiovascular disease. It's no coincidence that at the onset of menopause, we start to see women's blood pressure go up, their cholesterol go up, they're not sleeping, they're binge eating at night, their mood's going down, their libido's going down, they're not having intercourse, they're feeling disconnected to their partner, they're feeling socially isolated, they don't want to go out with their friends, they're feeling weight gain, they don't want to put their jeans on and go out. All of those things happen. So it impacts their health. But more often than that, it's really actually impacting women at work. So let's talk about the economic downfalls of not treating women. This is so significant. So this is research from Philip Sorrell, a mentor of mine, and he looked at this from 2015. So I'm going to tell you these numbers, but they're way outdated. So basically what they found is that per each woman with untreated just vasomotor symptoms, companies were losing a lot of money. And it was also raising the cost of healthcare. Because what happens to women? They don't want to go to work. They don't feel well. And they're maybe not as productive. Totally understandable. But then they're also doing what? Going to 18 different doctor's appointments. They're going to see the sleep medicine doctor, and then they have to go to the lab and they have to get their blood tests. And then someone said, go on day 4. And then like it's day 9. And then you've got to go again and start all over again, right? And then they have to go to the endocrinologist for the weight gain. And then they have to go to the nutritionist who's putting them on a diet, even though they're working out every single day and eating all the things that they're supposed to be eating. It's raising the cost of healthcare, not just, right, the loss of productivity, but it's also just impacting us in terms of our healthcare. So menopause in the workplace is something that I find that a lot of the solutions may be missing the problem. When I do surveys asking women, what's the symptom that bothers you the most when it comes to your quality of life? It's not hot flashes. It's not loss of productivity. It's brain fog, because nothing feels worse than not having a word, especially if you're standing on stage with a microphone, you're on a podcast, you're in front of a judge, you're in front of a patient, wherever you are. When you have brain fog, nothing feels more crushing to your self-esteem. When you can't finish your work, when you can't finish a thought, when all of a sudden you feel like you have ADHD, this impacts us so much. So what women need at work is not necessarily like a room that's cold where they can go have a hot flash. They need a few days off to go see a doctor and to get treated and to work on that journey. So hopefully menopause will have lactation rooms. I mean, menopausal women are not breastfeeding, but we did make strides, and that we got the ability for women to be able to have lactation rooms, right? And go put that into their workday. If we can find a way for women to put in menopause visits into their workday, that would help everyone tremendously. Compounded menopausal hormone therapy has been going through the roof to this day. That includes unregulated medications, pellets, that includes compounded prescriptions. This is not a billion-dollar industry. This is probably a multi-billion, if not trillion-dollar industry. Again, this data is fairly old and prices are increasing every single month. And the problem is that, again, when we don't have clinicians who are trained in FDA-approved hormone therapy, or who don't know what to do, so they do nothing, women will go and find unregulated medications. And this is where the true harm comes in. So my message here is always going to be the same, which is we may have differing opinions on what is harmful to women. No clinician, whether they disagree on the black box warning, wants to do harm to women. The difference is in what they think is harmful to women. Now, medicine, where doctors are trained to treat patients, is going to Silicon Valley because hospitals, large academic hospitals, private practices are not figuring this out. This is a crucial problem, because I would argue that nobody knows the patient better or the patient journey better than the clinicians who see the patients day in and day out, know what their questions are, know what they're experiencing, and know what they're up against. So if we don't really take this information and education and implement it in a scalable way within our own hospitals, which means from the emergency room doctors to the neurologists, to the psychiatrists, to the bariatric surgeons, to the doctors who are doing weight loss, to the internal medicine doctors and the family medicine and the nurse practitioners and the PAs, and then even the menopause specialists for the toughest of cases, we are going to miss this. And we're going to get protocolized medicine going to Silicon Valley, where to meet their margins, they're going to have to sell to them snake oil. So it's up to us to really take this time and say, we are going to reclaim medicine. So who should women be going to for help? I would argue that every single doctor should understand where their specialty intersects with midlife medicine, and they can begin to help them. I say all the time, young residents will come up to me and say, like, what certification do I need to prescribe hormone therapy? Do I need to have my Menopause Society certification to prescribe hormone therapy? No, nobody needs any certification to prescribe menopausal hormone therapy. Everyone can do it. And honestly, everybody should. Because if you ever want to see your patients say, you saved my life, well, I'm not an emergency room clinician. So, but patients will tell me all the time that I saved their lives. And it's such a satisfying thing to do. So this is a really interesting study, which is the likelihood of prescribing hormone therapy. And this study was done in 2017, but I bet it's not that far off today. So this study was done by Tyler et al., and they surveyed internal medicine residents and OBGYNs. They gave them 9 true or false questions based on large randomized controlled trials. This was not just like opinions that they made up. And they found that OBGYNs were about like 50%. Like the clinicians who we think like in our minds, or we still think they're the ones that are supposed to know about about menopause. Now, again, no one specialty is supposed to own menopause, but it is really a long-term and chronic health condition, right? The mean score among internists, pretty bad, like a 20 to 30%. And so the hypothesis that they had, though, was true. The more you knew about the large randomized controlled trials, the more you knew about the facts, the more likely you were to prescribe hormone therapy, not less likely. So one of the things we say all the time, especially when talking about the Women's Health Initiative, is this saying, did you read the study? Because if you read the study, that really serves as the fundamental safety and efficacy paper to end all papers when it comes to prescribing hormone therapy. The WHI was not a bad study. It was the way it got portrayed in the media after it came out. All right. So why don't more women take hormone therapy? This was a paper of mine. And I kind of thought, there's three main issues. Information on menopause is inconsistent and inaccurate and harmful. And it's 2026, and that is no different today than when I wrote this paper in 2020. Even after the black box was removed on menopausal hormone therapy, if you're in this sphere, if you're a clinician or if you were just a laywoman, you would hear two totally different perspectives. So that is still true. Nobody wants to be able to find a meaningful way to come together, right? So it's about doing no harm. Doing no harm to women. Nobody wants to do harm to women, but what is more harmful? Doing nothing out of fear or treating women who have autonomy and have consented to treatment. That's the first thing, right? The second is many clinicians have inadequate training, something I obviously care deeply about. So we need to get more education, right? To hospitals, to institutions, to residents, to medical students. And it's been just a dream seeing so many young residents and young clinicians really interested in this topic. And menopause is still socially charged. Believe it or not, we still live in a patriarchy. I don't need to spend time talking about that. But again, women's health, really in 2016, I remember when I was giving my grand drought, was kind of this cute topic and like, oh, this could be really fun and really niche. But again, this affects the entire population because what happens to the women happens to the whole household, right? Okay. So the studies that show the safety and efficacy of menopausal hormone therapy are crucial for you to know. So let's talk about the swinging pendulum of menopause. In the 1980s and the 1990s, the American College of Physicians in 1992 strongly advocated for the use of hormone replacement therapy for the majority of women. They said, oh my gosh, it looks like women live longer. It prevents heart disease. It prevents bone loss. This stuff is great. And so the NIH was like, well, we should do a randomized placebo-controlled trial. Let's do that. So that began in the late 1990s. However, in 2002, the estrogen plus progesterone arm stopped. That was the arm that was conjugated equine estrogen and medroxyprogesterone acetate in a one oral tab, one dose, one oral tab. Now, that's when hormone therapy became kryptonite. Medication stopped being prescribed, SSRIs rose, and education for clinicians was extinct. But in 2007, 2013, 2017, 2020, more data kept coming out on the post-hoc analyses of the WHI showing that, what we actually saw in those prospective studies that women live longer and have less heart disease was true. It's just that it was really time-based. So when women took hormone therapy within 10 years from their last period, that's when they really saw it. So again, the Women's Health Initiative is the pillar of where we get the majority of our data on estrogen. And what's funny is this was actually even on oral formulations that we don't even use as much to this day. So it gets even better from here. A friend and colleague of mine, Dr. Jim Simon, once told me something that I'll never forget. He said, I wonder what would have happened, right, if we did the Women's Health Initiative on a transdermal estradiol patch and prometrium. Would we be living in a different world? And maybe, but we didn't know then what we know now. So we can't say the WHI was a bad study. It just set us up for 2 decades of going a little bit backwards. Now, today, you have a removal on the black box warning. You have patch shortages. You have women, seeking care everywhere and not enough clinicians. So how did we get here? So I go over these studies in depth in my courses and in some of my podcasts. But the main thing you need to know about the Women's Health Initiative was this was a randomized controlled trial that was not done to look at controlling menopausal symptoms. The average age of women in the study was 63 and a half, so about 12 to 13 years out of the menopausal window. And they were looking to see if estrogen could be used as primary prevention to decrease heart disease, non-fatal heart attacks, and death. And guess what? They got some interesting results. And that's, again, because the vast majority of women were in their mid-60s, But also, a big chunk of women were over 20 years from their last menstrual period and put on oral conjugated equine estrogen, oral being key. Very few women were within 10 years of menopause. Only 17% were within 5 years of menopause. And if you had severe symptoms, they actually excluded you from the Women's Health Initiative because they didn't want to have too much confounding effects. They were looking at primary prevention, right? Giving estrogen to a woman before anything happened to her to prevent a heart attack. So what we now know is that the timing at which you start really matters. So if you start within 10 years, we do see clearly in the WHI, and I'll show you the data in just a second, reduction in all-cause mortality, reduction in heart disease, reduction in osteoporosis, improvements in quality of life, even reductions in diabetes, which to me, I think is wild that gets no attention, because diabetes is like the key to metabolic syndrome, which is the key to cardiovascular disease, which is the leading cause of death in women. To me, this is crazy that this got no press. Now, we're going to talk about why people disagree on this in just a second. When they looked at the post hoc analysis, again, they actually split it up between women who are between 50 and 59 or within 10 years from their last menstrual period. I am a big fan of years since last menstrual period because I have a patient, I just saw her 2 weeks ago. Her last menstrual period was 58 and she's 67 and she got told she was too old. She couldn't take menopausal hormone therapy. Well, she's within 10 years of menopause. She is squarely within 10 years of menopause, right? So why do we cherry pick? So they found in this post hoc analysis that the total mortality was 0.73, which means there was a protective benefit if you started HRT within 10 years of menopause, right? And that women who were in their 60s had really a null effect of estrogen on cardiovascular disease. It did not worsen it. It didn't give them the major benefits that women got when they were older. And really, there was a slight increased mortality among women in their 70s. And again, these women were started on oral estradiol. So this kept going in 2017, and this really set up the foundation for other trials to start showing data for women closer to the age of menopause. The Danish osteoporosis prevention study is a study I point to all the time, showing that women who started menopausal hormone therapy closer to the last menstrual period, on average, these women were like around age 50, right? And took different formulations. So now we're starting to see different formulations. So oral estradiol, that's 17-beta estradiol, is your bioidentical estradiol. So that's oral, and norethindrone, which is a synthetic progestin, showed reduction in risk of mortality, so risk of dying, heart attack, and heart failure, with no increased risk of cancers, clots, or strokes. So this is the first time we start to see this. Next, we have the Kronos Early Estrogen Prevention Study, actually also done by or led by Dr. Joanne Manson, who's one of the lead authors in the WHI. Again, thinking, we need to look at women closer to the last menstrual period, closer to menopause, and look at different formulations. Then they used, placebo conjugated equine estrogen. So that's your Premarin, slightly lower dose than they used in the WHI. And then transdermal estradiol, and then micronized progesterone. And again, they found, improvement in bone density, improvement in cardiovascular markers, improvement in insulin resistance. And then, of course, all the things that you would expect from menopausal hormone therapy, like less hot flashes, less GSM, and no adverse effect on cognitive function. Now, this is actually in there because part of the Women's Health Initiative, called the WHI-MS, the Women's Health Initiative Memory Study, is the study that confused a lot of us on the brain effects or the dementia risk of menopausal hormone therapy. In that study, women were 65 years and older, and they found a slight increased risk of dementia. But again, those women would therefore be on average, 15 years out of menopause on oral estrogen. So the hypothesis now is that, again, earlier, maybe transdermal, maybe our bioidentical formulations are better. The ELITE trial is really the study that showed that the timing matters. And Dr. Howard Hodis, another great friend of mine, he looked at subclinical atherosclerosis. So that's sort of the plaque buildup in your arteries as sort of a clinical marker. And again, found that when menopausal hormone therapy was started early, within 6 years of menopause, there was no measurable increase in carotid artery thickening. Oh my gosh, now I'm losing my words, right? There's the brain fog. But if you started after 10 years of menopause, there was. So the pathophysiology here is that when estrogen started within 10 years of menopause, it acts in a anti-inflammatory way. It releases nitric oxide, opens up the blood vessels, good blood flow, good things happen in your heart, in the vaginal tissue, probably also in the brain. in your bones, all good. But if it's more than 10 years, then it may be a little bit pro-inflammatory. Now, the WHI showed that for women who are 60, in that 10-year window of 60 to 70, there was sort of a null effect overall on cardiovascular disease. And remember, that was on oral. So in my strong opinion, women who are, 20 years out from their last menstrual period are still good candidates for transdermal estrogen. There's nothing magical about the age of 60. We need to look at last menstrual period. We need to look at formulation. We need to also look at the route in which you're prescribing it and the data. So this is looking at cardiovascular risks. And when I used to teach to residents, young residents, they would just be like, wow, I can't believe this is so interesting. When you look at coronary heart disease and all-cause mortality, this is the DOPS, the Danish Osteoporosis Prevention Study. That's the DOPS trial. You can see the WHI and the post-hoc analyses and some meta-analyses. Do you see the reduction in coronary heart disease and all-cause mortality? And this is women starting estrogen within 10 years from menopause. So in fact, the doctors in the 1980s and the 1990s were right. It was helpful. When we did the randomized controlled trial, we used one dose, we used one route oral, we used one formulation, conjugated equine estrogen, medroxyprogesterone acetate, and those women were on average age 63 and a half. So we do see improvements in cardiovascular disease. And this is why all cardiologists must know this incredible information, because there's so much more research here that needs to be done. Now, what about breast cancer? I was actually just doing a podcast, Core IM, and I spoke with a resident. She was asking me, about to just talk a little bit about the risk of estrogen and breast cancer. So we'll make this brief because we could talk about this for a long time. Now, in the WHI, there was an estrogen-only arm, and you could only be in the estrogen-only arm if you did not have your uterus. It was surgically removed, and those women had statistically significant reductions in breast cancer. That should have been a dropper right there. That should have been in the news, but it wasn't. Now, the study was actually stopped because the PremPro arm, the conjugated equine estrogen and medroxyprogesterone acetate, was where they saw the slight increased risk of breast cancer. The media reported this as a 26% increased risk of invasive breast cancer. For the lay women, they would think that means like 1 in 4 women would get breast cancer, right? But again, when we break that down, it's really about 2 to 4 women out of 1,000 over 5 years who were in this study on oral Premarin who got breast cancer, which is a lot different. As we're starting to think about this, we think to ourselves, the women who took conjugated equine estrogen alone had reductions in breast cancer. Is only in the women who took the medroxyprogesterone acetate. What if it's the MPA? Right? So then they looked at different formulations of progesterone and basically found that if we swap that progestin out for progesterone, the bioidentical form, we don't see any increased risk of breast cancer above baseline. In fact, in 2002, maybe, I think in 2002, at the Menopause Annual Society meeting, I presented this paper because I was on a panel of like the most important papers that came out this year. Of course, it was at the very end of the conference. And this is the paper, if you want to take a look at this, that really showed that estrogen was not associated with an increased risk of breast cancer, which is crazy. That idea that estrogen increases breast cancer risk is ingrained, especially in our oncologist minds, which is why we need oncologists involved in the menopause, stratosphere. But that maybe it was the progestins. And then when we swap out progestins for progesterone, you literally see an odds ratio of 0.99, which is basically a null impact of risk of breast cancer using estrogens and then adding micronized natural progesterone. So imagine that. I get this question all the time. Well, what about if a woman is at high risk? Well, she might be at high risk. Let's just say it's X plus 1. But starting her on menopausal hormone therapy means her risk is still X plus 1. She still knows she's at slightly increased risk no matter what she does. And staying away from menopausal hormone therapy isn't going to keep the breast cancer away. Now, it may cause it to grow faster if it's going to be there, but she's already under surveillance. And what about her quality of life in that time? The idea of doing nothing is, again, what's harmful to the patient. It kind of depends based on what you see and where you are as a clinician. And also as the woman, what feels more harmful to you? Why don't women get any say? So women at high risk, even women who've had risk reducing oophorectomies, we find that they should be on menopausal hormone therapy, and that when they are, it does not increase the risk of breast cancer, even in patients with BRCA1 and BRCA2. Now, the last thing to talk about is blood clot risk, right? This is what patients are so worried about. We don't worry about this when we prescribe birth control pills to young women. We don't worry about this when women get pregnant or when they're in their postpartums. We do, but there's no one we scare more than a menopausal woman about a blood clot. And I'm going to tell you, if you have gotten to the menopausal age and you've been on birth control pills for 10 years, you've had a few kids, you've had surgeries, you've not had a blood clot, it's likely that you're not going to have a blood clot with postmenopausal estrogen, which is significantly lower estrogen exposure than your whole premenopausal life. And the ester studies are the trials that actually show that transdermal estrogen does not increase the risk of blood clots above your baseline. Same thing with the breast cancer risk. If you're a slightly higher risk of a blood clot, even if you have a mutation, it's X+1. If you take hormone therapy and you use transdermal estrogen and progesterone, it's still X+1. You're still at higher risk, but you are going to have reductions in your symptoms and you may have improvements in your long-term health outcome. And this is what the ester studies show. And so if you want a deeper dive on this as a clinician, you should definitely look these up. So I love this. This is really from the Women's Health Initiative itself. So let's go all the way back to the WHI, right? Let's go back to Premarin. Let's go back to Prempro. Look at these benefits for estrogen alone. You see reduction in diabetes, all fractures, all cancer types, colon cancer, all cancer deaths, all-cause mortality, breast cancer, and stroke. You see a slight increased risk for PE and DEBT, and they are not even statistically significant. And this is on oral estradiol. Now, if we look at MPA, yes, we do now see all these benefits and we see the slight increased risk of breast cancer. The only thing that has a statistical significance is the risk of a DVT, which we know is slightly higher on oral than on transdermal. This is where I say I could cut this little thing out and like put it under my pillow and sleep on it at night. This is where I feel safe prescribing menopausal hormone therapy to my patients because the vast majority of my patients use transdermal. Not all. Some patients are great candidates for oral estradiol. Look at the benefits even with conjugated equine estrogen. It's crazy. Now, the black box removal was an exciting thing that I never thought I would see. And this is what many of us on the panel were saying, is that estrogen is extraordinarily safe. And if we go back to that slide I showed on why the U.S. Preventative Service Task Force says estrogen gets a grade D, a lot of those can be, I don't know if debunked is the word. It actually is, a lot of those can be shown based on science and evidence that those are incorrect, right? But we can't change their minds. But what we could do was help to do one thing, remove one barrier for patients and one barrier for clinicians, because it is scary to prescribe something with a black box, right? It is scary as a patient to go home and then get it and then not use it. And what the FDA did was say, hey, we are no longer requiring that the black box be on these medications, and the pharmaceutical companies can be sure to put the risks and benefits in their pamphlets where they see fit. And doctors can prescribe them how they see fit, right? And there was a lot of controversy if this was right or wrong, or if this was good or bad. And this is, again, why women are still confused, because we can't agree. What we can agree on for sure is that no one wants to do harm to patients. And some people feel like this may induce harm to patients because they're going to be put on menopausal hormone therapy and they don't need it. But that's missing a little bit of the point, is that most women are good candidates for menopausal hormone therapy. And most women don't know how they're going to feel on menopausal hormone therapy until they trial it. And what I say all the time is that women do deserve a trial of menopausal hormone therapy for their symptoms. Who am I to say what's severe and what's not? How am I to know if your joint aches and pains are from menopause or they're from osteoporosis? If we have such stringent, ideas on who is the perfect candidate for menopausal hormone therapy. Now, I advocate strongly that clinicians, definitely use their discernment, that clinicians prescribe to what they feel is best for them and their patient. But I do want clinicians to really learn the safety and efficacy and the value of using menopausal hormone therapy off-label, on-label, and help diagnose some of these things. Now, I just want to get into very briefly some high-level things about prescribing and some tips and tricks for you as a clinician. So I like to do something called hormone stacking. And in hormone stacking, we start with one hormone at a time. Why? Because over my years, I've seen so many women come to me and say, I tried menopausal hormone therapy and it didn't work. But guess what? It was just one piece of hormone therapy. Maybe it was just the progesterone that caused water retention or worsening mood, and they thought menopausal hormone therapy didn't work for them. But if they knew it was the progesterone, they could find a different formulation or a different dose. I've had patients say, oh, I tried hormone therapy and gave me weight gain and breast tenderness. Maybe their dose was too high and they needed to actually lower it. So I like to do one hormone at a time, something I call hormone stacking. And so if you're starting with estrogen, it comes in oral, transdermal in terms of patches. There's also gels, there's sprays, and a ring. And they come in lots and lots of different doses. And you can see there's even different formulations. You've got your conjugated equine estrogen at the top, and then the rest are basically all 17 beta estradiol or your bioidentical estrogen. There are combinations as well, and this can work really well for women who are done menstruating. Maybe they're a few years out of menopause. This is a great time to use a combined medication. Patients are maybe less likely to bleed. I don't typically start with a combined medication, but if you're just starting out, learning how to prescribe a combi patch, which is a combination of estrogen and progesterone in one little sticker, is a great way to get started. So you can do combinations orally, or you can do them in the patch. Those are how you could do combinations. And then for progesterone, most clinicians now start with prometrium. Why? Because we just said that when we look at the risk of breast cancer with prometrium, there's a null impact, right? So with bioidentical prometrium and an estrogen, it actually doesn't matter if it's conjugated equine estrogen or 17 beta estradiol, but we see no increased risk of breast cancer above baseline. So prometrium is the place that most clinicians start. But there are other forms of progesterone, and women will need to use these if they have progesterone intolerance or if another form of progesterone is better for them. And that is A-okay. Because it's not enough to just know how to prescribe one thing and one thing only. It just won't work for all women. Beta-doxephene and conjugated equine estrogen combined is Duave, a highly, highly underutilized medication, which is really, really fascinating. So beta-doxephene is a cousin of tamoxifen, is a cousin of Avista. So it actually shows for women that it can reduce menopausal symptoms because it's got the estrogen, but also there's no increased risk of uterine cancer because the beta-doxephene is an antagonist at the uterus. It actually blocks and degrades the estrogen receptor. So this is a great once daily oral medication. And we use this a lot for patients who are maybe already at high risk for breast cancer, meaning they have ductal carcinoma in situ or stage 0, but they do want to take menopausal hormone therapy, or they've had a history of breast cancer and they do want to go on menopausal hormone therapy. And after a lot of counseling, learning about their prognosis, their stage, and their treatment, they are good candidates for hormone therapy. Duvet is often an option that we will use. Now, it does have a slight increased risk of DVT because, again, it is oral conjugated equine estrogen, so something to know about. Now, timing and duration of use. Once you start a patient on menopausal hormone therapy, it is shared decision making from there on out. There is no time at which you must stop. This idea that you had to stop at 60 or after 10 years all came from the WHI. But what's important to know is that in the WHI, that's when they started menopausal hormone therapy, but there's a big difference if you do start within the window. And you shouldn't stop your hormone therapy just because. It should be shared decision making. And I always tell my patients, I will never rip it from you just because, but I also never force it on you. One thing about menopausal hormone therapy that I think is very interesting is that, like, there's this idea too that you should take it and you should take it for life, and there should be one way to do it, and you should be on it and you should be on it forever. No, I don't believe in that either. I talked about how you could use it diagnostically. So you could try it for 6 to 8 weeks and be like, didn't help anything, and I don't want to take it. Okay, great. Or you could take it for a few years because in the WHI, the benefits, like, they lingered around. Like, you were only on it for 5 years and you still got these benefits. So we also don't pressure patients to stay on their menopausal hormone therapy. And it's clear I don't gain anything when women take menopausal hormone therapy. My mission is to help educate clinicians on what they don't know that they don't know, and patients on what they don't know that they don't know. But menopausal hormone therapy isn't the one right answer for everybody. It's just that women and clinicians deserve the whole story. So the Menopause Society used to be the North American Menopause Society, now renamed the Menopause Society. Again, their position statement, their last one on menopausal hormone therapy, is that the benefits outweigh the risks for women who take menopausal hormone therapy within 10 years of menopause. You know what it's approved for, but there are also many studies that they talk about at these meetings that show benefit. So for example, transdermal estrogen is great for mood, and yes, it can help with other things. And so this is so important. For younger women, they should be on menopausal hormone therapy, and treatment should be individual. individualized. It's not the lowest dose that doesn't work, it's the lowest dose that works. All right. There are non-hormonal options as well. And I have patients in my clinic on non-hormonal medications. Again, it's all to say there's not one right answer. But the non-hormonal medications that are FDA approved are not going to help with the heart, not going to help with the bones, not going to help with all these other preventative things. So the newer CanDY receptor antagonist is Veozah, and the newer one, which I can never pronounce correctly, so I'm not going to give it a shot. But these two medications are really great at reducing hot flashes and night sweats and can help with sleep. Brisdell, or paroxetine salt, 7.5 milligrams, is an SRI. And I find that the CanDY receptor antagonists are a little bit better targeted to treat symptoms. When it comes to off-label medications like the SSRIs or SNRIs, to be honest, I don't use these very much. And one sort of key thing for clinicians to know is that actually the lower dose is better. So if a patient's already on, say, citalopram for generalized anxiety disorder, sometimes I see clinicians increase it to see if it will more kind of help the hot flashes. No, actually it doesn't, and it could just make them more sedated. So I'm going to skip over GSM, but all I want to say about GSM is that vaginal estrogen is extraordinarily safe. In studies where they look at serum levels, these serum levels do not get above what most women are postmenopausally at, except for if you use estrase cream every single day for 1 or 2 weeks, you might see a little bit of a spike in that serum level, but it's really not clinically significant. And what's important is that it comes in many different doses, many different ways for prescribing it. So we find in research that only a third of women like the vaginal estrogen that they were given. And so knowing that you can use cream, or you can use the suppositories, or you can use them more often than twice a week, or you can try the ring, really helps patients get the right treatment for their genitourinary syndrome of menopause. And then finally, what about vaginal estrogen and breast cancer risk? All patients should and can, all women can and should use vaginal estrogen. And we see from so many studies that vaginal estrogen is not systemic, and it does not increase the risk of breast cancer, nor does it increase recurrence in women who've had a diagnosis of breast cancer. And this is a great study. This is from JAMA in 2024. Vaginal estrogen compared to non-hormone therapy users, there was no evidence of a higher risk of breast cancer mortality in women who had breast cancer. And those are the patients that have severe GSM. All right. I'm going to summarize this with just a couple of my tips and tricks. So I like to reverse engineer menopausal hormone therapy. What does that mean? So the first thing I think about is, does the patient have a uterus or not? That's going to tell me if she needs progesterone. The next thing I think about is, the patient have any red lights or contraindications to menopausal hormone therapy? Does she have any yellow lights, which means, I'm going to stop and think. I'm going to almost always use transdermal estrogen for my patients. Then I want to know about her lifestyle and her preferences, and I want to know her goals and what symptoms are bothering her the most. That's how I'm going to start to hormone stack. So that means if she says, okay, I in perimenopause, I'm still bleeding. So, okay, I know she has her uterus, and my biggest symptom is anxiety and insomnia. I may start her on nightly progesterone and then have her come back to see me in 2 to 4 weeks, and then get the dose, the route, and the formulation of that correct before we go on to adding, let's say, estrogen or testosterone or vaginal estrogen. So this, again, is my way of making sure that patients succeed on menopausal hormone therapy, because the cowgirl effect is what I was trained in. What I usually do, I was like, okay, here's your vaginal estrogen. I would have the patients leave they're like, okay, so here's your progesterone, take that every single night. And then here's your patch, do that every 3.5 days. And then here's your Vagifem, do that 2 nights a week. And then here's your testosterone, put that, and maybe I'll send you Addyi to take that at night too. I would leave patients when I was just a baby doctor with all the things, because I wanted to be as helpful as humanly possible. And I wanted them to leave being like, yes. But the first visit's not the most important. It's the second, it's the third, it's the fourth. It's where you make the tweaks, it's where you make the changes after you starting to prescribe. So start with one and then add, okay? Progesterone, should you do it cyclically or continuous? This is a question I get asked all the time. So I always actually tend to start my patients on continuous progesterone. Why? Because one, I think when you're first starting out, if you're not sleeping, if you have brain fog, if you're cranky, like remembering what day of the month it is just another thing for you to do. And if we take it continuously, we'll find out if you do well on progesterone or if you don't do well on progesterone. And then when you come back, we will decide what's best for you. I tend to have the majority of my patients use it continuously. It's easy to remember. And then we cycle it if it's a little bit bothersome to them and or they would rather just use it, 12 nights of the month. And of course, you want to make sure that your progesterone dose is correct. And a lot of this is based off of the final estrogen dose that your patient's going to have. Progesterone intolerance is something that I find so interesting. This is something newer in the sense that like women as I've just been training women for the years, will come to me and say, I feel like it's making me suicidal. I have heard crazy things. And we take the progesterone off, and that symptom goes away. So, this is a paradoxical response to progesterone, either the conversion of progesterone to allopregnanolone in the brain, the way it binds to GABA receptors, or if the GABA receptors just stop working. I don't know what it is, but some women have progesterone intolerance. And to deal with this, we have to first name it, we have to do studies on it, and then we have to change the way they take progesterone. So they either need to go to a synthetic progestin, which is still okay. Like, yes, we said progesterone is so great. It doesn't shows not to increase the risk of breast cancer. But if the patient needs to go to a synthetic progestin, we have to stop saying that one route and one dose and one formulation is the only perfect thing. So there's many options. There's synthetic progestins. There's an intrauterine device, which doesn't release progesterone systemically in vast majority of women. And then there's Duave, my friend that I talked about earlier. So there's lots of different ways we can treat progesterone intolerance. Bleeding on menopausal hormone therapy is a huge, huge topic. And I think it's the one that makes most doctors who are not gynecologists like afraid to step into menopausal hormone therapy. But I promise you can handle it. And a lot of times women do bleed, and it's normal in the first 4 to 6 months after starting on hormone therapy. If you saw the new ACOG guidelines, so that's the American College of Obstetrics and Gynecology, they just came out with new guidelines saying that women who have postmenopausal bleeding after one incident should have not just an ultrasound, but also a biopsy. Like, they're coming for you. You saw this? Yes. Okay. Now, what's really interesting in the studies is that in the meta-analyses, they pulled out women who are on hormone therapy and women not on hormone therapy. And they actually found, so this was women having bleeding, that the women on hormone therapy were actually much less likely to have uterine cancer. And this is my thought here, is it's actually because women on hormone therapy are hopefully right on a progesterone, and therefore they're getting the benefits of progesterone, whereas women who don't take hormone therapy at all are not getting any effects of progesterone. So that was very interesting. But postmenopausal bleeding can scare women, can cause unnecessary procedures and unnecessary workup. It is normal, but there's things that we can do as menopause clinicians, right? We can try increasing the progesterone, we can try lowering the estrogen, you can try both. You could do, an ultrasound to evaluate for a fibroid or a polyp, which is likely to be the causative thing if there's an anatomical reason for bleeding. Cervical polyps, if you're a gynecologist, you know that they bleed like crazy, and cervical polyps are a real big reason women can have bleeding. Now, yes, I do, of course, don't want anything to happen to our patients. So we need to do the next steps when necessary. But I do think for those gynecologists out there, I think separating and pooling women just on menopausal hormone therapy and studying like when should you really do more of a workup for them should be like a separate study than women not on hormone therapy, because we're pulling those together and we're scaring women because still only 5% of women are on menopausal hormone therapy. And the data for them is even, when it comes to uterine health, better. All right. We know that premature and early menopause must be treated with menopausal hormone therapy. Testosterone replacement is something that a lot of women are interested in these days. And the consensus is to use transdermal physiologic doses. So for that, I like to use Testim and Androgel, and you're just going to use 1/10 of the dose. So I tell my patients, take this tube, take this packet, and make it last 10 days. There's lots of myths about perimenopause. And the biggest one by far is that you have to wait till 1 year of no periods to use menopausal hormone therapy. And that simply couldn't be farther from the truth. If you ask me, birth control pills, ethinyl estradiol, and norethindrone is hormone therapy just as transdermal estrogen and bioidentical progesterone are. So why aren't we giving more women in perimenopause postmenopausal hormone therapy, particularly when most clinicians see that for whatever reason, the menopausal doses seem to have better efficacy in reducing those hot flashes, night sweats, brain fog, irritability, and all the other things that I tend to have. So dose route formulation, that's something that I always teach. When you are tweaking, when you're trying to get your hormone therapy right, is a dose too high? Is it too low? Is it transdermal and you actually need to go to oral? Is it oral and you need to go to transdermal? Are you on a weekly patch when you need a daily gel? And formulation. There is a patient of mine and she is on Prempro. I know. Can you believe it? Yes, that's right. And she feels so guilty about this. She's like, I can't believe I'm on Prempro. She's tried everything else and Prempro works the best because for some women, the difference in the formulation makes a big difference. So again, don't cross any of these off as dangerous or unusable. And it is a-okay to add local estrogen to systemic hormone therapy. So if you are on, I hear this all the time, my doctor won't add vaginal estrogen because I'm already on systemic hormone therapy. I'm already on the Combi patch. And I say that's crazy. You can always add local vaginal estrogen to your systemic hormone therapy because sometimes you need it right in the area where you need the treatment. Okay, here are my takeaways for you. Whew. First of all, thank you so much for listening. It's been at least an hour of me talking and thank you for giving me the opportunity to stand up here and hold the microphone and teach you something. And I hope you're learning a lot. Menopause is not a gynecologic issue. Okay, yes, it is, but it's not a cardiometabolic event. It's not when your risk for cardiovascular disease goes up. It is when your risk for diabetes goes up. It is when lipids start to increase. It is when we start to lose sleep and then we develop hypertension and we develop overeating and binge eating and all of these things. It is a cardiometabolic event. And we either get in that window where this is happening and protect women or we don't. Now, it doesn't have to be just menopausal hormone therapy, but we do have to recognize that data shows again and again that women who take hormone therapy within 10 years have reductions in all-cause mortality and cardiovascular death. So cardiologists, I need you on board. Menopause is a neuroendocrine event, which means that these hormones play the biggest role in our brain. They affect our mood. They affect our cognition. In fact, hot flashes stem from the brain, right? This is the hypothalamus. That is vasomotor symptoms at its best. So it is a neuroendocrine, and the endocrine stands for the diabetes and the bone loss. All of these things are interconnected and make it so much bigger than just your periods stopping. So the stakes are high. That's my end message here, right? Menopause affects everyone. It crosses every specialty. It impacts the way we are going to age. It affects our communities. It affects our economy. It affects our hospital systems. It affects so much. So my call to action here is whatever specialty you're in, whether you came just kind of because you already love this topic, which is probably true, then I want you to grab your friends who are in different specialties and across the aisle and all these things and bring them in, because this is really where we're going to make the biggest impact, I think, in care going forward, reducing the cost of healthcare, making hospitals more efficient, having actually people work together can all be brought together by this one little cute thing I talked about in 2017, which is menopause, right? And we don't want medicine getting outsourced. Okay. We don't want medicine going to venture-backed capitalists. We don't want it to going to private equity. Can it? Sure. Is it all bad? I don't know. But could we do it the best? Yes. So let's do it the best. That's probably my take-home message for today. Thank you guys so much. If you want to learn more, I love teaching and I have so many courses and so many amazing colleagues teach other amazing courses. And again, we have urologists, we have an orthopedic surgeon, we have gynecologists, we have physician's assistants, we have internal medicine, we have obesity medicine specialists. It takes a whole team.